Hello, everybody. I wish you all very welcome to this workshop by ICRP Task Group 36 on radiation doses to patients in diagnostic nuclear medicine. My name is Sigrid Leide-Svegborn, and I'm a medical physicist at Radiation Physics, Skåne University Hospital in Malmö, Sweden, and associate professor at Lund University in Sweden. At this workshop today, we will present the work behind the upcoming ICRP publication of the Task Group 36, which is on radiation doses to patients in diagnostic nuclear medicine. The draft document is currently available for public consultation at the ICRP webpage, and it will be there for until 5th of September. And we are very happy for this opportunity to introduce the report and put it into perspective today. The agenda for the workshop today is as follows. We start with 6 presentations, which will give you more details behind the work of this task group and this publication. This will be followed by a roundtable discussion with representatives of several stakeholder associations. The workshop will end with a Q&A session where you will have the opportunity to put your questions in the QA box in Zoom. And I will read the question and forward the questions to the appropriate persons. And I'm delighted to introduce the speakers and their topics, and I will read them now. So first, there will be an historical overview by Dr. Dietmar Noßke and Dr. Makoto Hosono. Dietmar is a mathematician with main field of work in internal dosimetry. He has worked for several decades at the Federal Office for Radiation Protection in Germany, and he is now retired. He was the former chair of this task group. Dr. Makoto Hosono is a radiologist and nuclear medicine physician with main area of expertise in positron emission tomography and radiopharmaceutical therapy. He is professor of radiology at Kindai University Faculty of Medicine, Osaka, in Japan. Then Dr. Augusto Giussani, the chair of the task group, will give us new features and hot topics of this new report. Augusto is a physicist with main areas of activity in biokinetic modeling and internal dosimetry. He works at the German Federal Office for Radiation Protection in Germany. This is followed by a presentation on a special case important for the internal dosimetry in nuclear medicine, namely the dynamic urinary bladder model, which will be presented by Dr. Martin Andersson, and his medical physicist and associate professor at Department of Radiation Physics, Institute of Clinical Sciences at University of Gothenburg in Sweden. And his focus is on biokinetics in internal dosimetry. Martin will then continue and also give us information about the electronic data and the dose viewer app. Dr. Alexandra Kamp, who is a physicist at Federal Office for Radiation Protection in Germany, is going to present a comparison between the new report and previous publications. So this part of the workshop will end by a presentation on future trends and applications in diagnostic nuclear medicine, and that will be by Makoto Hosono and Dr. Keon Kang. And Dr. Keon Kang is a nuclear medicine physician and professor at Seoul National University College of Medicine in Korea. And after this, the roundtable discussion will take place, and this will be with representatives of stakeholder associations, and it will be moderated by Augusto. So I will be back at the end of the workshop moderating your questions in the Q&A part. So that will be at the end, and I ask you to put the questions there in the Q&A box. So I'm very happy to give the floor to the first speaker, and that will be you, Dietmar. Thank you.
So thank you, Sigrid. So I will give a historical overview on the task group 36. This group has a very long history, and this long history is strongly connected with one person, with Søren Madsen. And I regret very much that he cannot give this presentation because he's just recovering from an infection. And I wish Søren all the best and will try to give this presentation. The ICRP Task Group 36 is a task group under two committees, Committee 2 and 3. Committee 2, doses from radiation exposure, brings in the expertise in dose calculations, and Committee 3, radiological protection in medicine, brings in the expertise in the application of radiopharmaceuticals in medical diagnostics. The objective of this task group is to develop dose coefficients for radiopharmaceuticals administered to patients in diagnostic nuclear medicine. I still have said that this task group has an extremely long history. Usually an ICRP task group works for a few years. This works since the 80s of the last century, and all the time it works on doses to patients in nuclear medicine. It was for a long time the radiopharmaceutical task group, and since the year of 2009, it has got the number 36. Now it is the task group 36. This presentation will be more general to give an historical overview on ICRP publications dealing with radiation doses in diagnostic nuclear medicine. So the first publication is from the year 1971, ICRP publication 17, protection of the patient in radionuclide investigations. It was prepared not by a task group, but by a single person, by Roy Ellis. And this publication was published in parallel to ICRP publication 16, protection of the patient in X-ray diagnosis, which was prepared by a task group of Committee 3, which was chaired by R.F. Braun. In ICRP publication 17, this publication describes the basic principles for minimizing the dose to patients receiving radiopharmaceuticals. It presents a compilation of estimates of the absorbed doses resulting from the administration of the more commonly used pharmaceuticals. And so for 92 compounds, there were absorbed dose estimates and literature references. In the year 1988, ICRP published its publication 53, radiation dose to patients from radiopharmaceuticals. And this publication is the starting point of a series of publications. It was prepared by a task group, at that time only a task group of Committee 2, not yet Committee 3. This task group was chaired by Bertil Noßke, and also Søren Madsen was a member of this task group at that time. So from the beginning, he works in this task group. And also my teachers, Alexandra and Hans Detlef Rödler, were members of this task group. This publication contains absorbed doses for 20 organs and tissues and effective dose equivalents for 5 age groups, reaching from 1 year to adults, and covers about 120 radiopharmaceuticals. The dose calculations were based on biokinetic and dosimetric models similar to those which were used in ICRP publication 30, which gave doses to workers. But there are some more specific biokinetic models which were specific for radiopharmaceuticals, for example, for urinary and biliary excretion, and it used dosimetric parameters derived from age-dependent mathematical phantoms. Then a series of addenda followed this publication 53. The first addendum, addendum 1, was published within ICRP publication 62. Now the task group which was preparing this publication was a task group of Committee 2 and Committee 3, and Søren Madsen was now chair of this task group. He was it for a very long time, for several decades, and also Sigrid Leide-Svegborn was a corresponding member of this task group. This addendum contains models for 6 additional radiopharmaceuticals and also a recalculation of effective dose coefficients, at least for adults, according to the system which was recommended by ICRP publication 60, and while in publication 53 it was still based on the system of publication 26. The next addendum of ICRP publication 53 was ICRP publication 80 from 1998. Now Jan Liniecki, at that time vice chair of Committee 3, was a new corresponding member of the task group. And this addendum contains models for 10 additional radiopharmaceuticals and recalculations for 19 most frequently used radiopharmaceuticals, which were introduced in publication 53, now considering age-dependent urinary bladder voiding intervals and the concept of ICRP publication 60 for the calculation of effective dose. It contains also a reprint of addendum 1 with slight corrections and recalculations. Addendum 3 of ICRP publication 53 was ICRP publication 106. Now I also have joined the task group. Here is a picture of a meeting in Malmö. There were many nice meetings in Malmö and many pictures always before the same bush, and showing Jan Liniecki, Mike Stebbin, David Taylor, Sigrid Leide-Svegborn, Lennart Johansson, Søren Madsen, Bertil Noslin, and me. This addendum contains models and doses for further radiopharmaceuticals, partly published in interim reports before on the website. Recommendations on, and also it contains recommendations on breastfeeding interruptions for various radiopharmaceuticals. So here were also material which was partly published in interim reports before, and these interim reports on the website were more and more frequently. We were much more flexible to publish new values on the website and then to wait until we have material for publication, for a new publication. And so more and more information were given on the website. There was one official addendum 4 to ICRP publication 53, which was at that time, 2013, only published in the web. It contains models and dose coefficients for 6 further radiopharmaceuticals and a few corrections to ICRP publication 106. So there were very many addenda to the ICRP publication 53 and partly given in publications, partly given on the website. So there was the need to have a compilation of all the radionuclides which were considered so far. And this has been published in a compendium of the current information related to frequently used pharmaceuticals in publication 128, which was published in 2015. And at that time, also before Augusto Giussani, the present chair, was part of the group. And this publication 128 contains the compendium of all available information for widely used radiopharmaceuticals, which were also published so far, and is still based on, but it is still based on old biokinetic and dosimetric models. Old biokinetic models, this means, for example, the old gastrointestinal tract model, not the new human alimentary tract model, and simple compartment models for the systemic activity and no physiologically based recycling models. And for dosimetric parameters are still based on mathematical phantoms and voxel instead of voxel phantoms. And it is still, the effective dose was still calculated with the effective dose of publication 60 and not of the system of publication 103. This means there is a need of revision of this publication 128, which is being done now, but there is also some more need. So is a clinical significance to have very good values for doses by radiopharmaceuticals. And publication 128 has long served as the global reference, but we have seen that it's not up to date, and therefore we need this to have the best information and latest recommendations for the comparison of the nuclear medicine techniques, for example, with other imaging techniques like CT and MRT to get reasonably accurate dosimetry for comparison of the risk of different techniques, and in daily, and to have also component for ethical review in daily practices and clinical studies to be able to get a good value for the risk which is due to this imaging procedure. And Augusto Giussani will report in the next presentation on the new features and why it is needed. He will say it in more detail. And the present membership of this task group, which is doing the work of revision of ICRP publication 128, is shown here. Augusto Giussani is now the chair of the group. Søren Madsen is still within the group, and my co-author Makoto Hosono is also a member of this group. He comes from Committee 3. And this is working on the now on the revision of ICRP publication 128, which is described in the next presentations. Now, the future of the task group 36, now after more than 40 years, it will end its long history after the publication of the revision of ICRP publication 128. A new task group will start to work, task group 130, doses from diagnostic radiopharmaceuticals during pregnancy and breastfeeding. This is a task group again under committees 2 and 3, and it will be chaired by Sigrid. And this task group will also continuously publish models and dose coefficients for new radiopharmaceuticals on the website and in ad hoc addenda. So the task group 36 will now stop to exist, but its work will still be alive and be continued within task group 130 and perhaps in following task groups. I thank you for the attention.
Thank you very much, Dietmar. So now I take over with the second presentation. And as Dietmar just said, I will talk a little bit about this new document, which, as remembered at the beginning, is currently in under public consultation, and you can find it on the web page of ICRP. So we have seen the history of ICRP. There have been a number of documents presenting those coefficients for radiopharmaceuticals in diagnostic nuclear medicine. And the objective of the work that we have published now is to update the publication 128, to update the dose coefficient according to the new recommendations. I've put here new in quote marks because actually the recommendation of ICRP is from 2007, are not that new, but we need to update those coefficients. And there are a number of features that have to be considered. First of all, with publication 103, we have a new definition or a new way to calculate the effective dose, because now we calculate the dose to the tissues, averaging between the dose to the male reference person and the dose to the female reference person. So you have a sex average organ equivalent dose, and then you sum these organ equivalent dose, waiting for the tissue weighting factors to get the effective dose. There is a new definition of target tissues or organs which have a specific weighting factors. Then there are other organs which are still relevant for the calculation of the effective dose, but they don't have a specific weighting factor, so they are all put together, pooled in a general so-called remainder. And also here, the definition of the calculation of the dose to the remainder is different than it was in the previous recommendations. So we have simply an average of the doses to the different tissues that are part of the remainder, but still we have a different composition between male and female. And also there are some differences in the weighting factors. So based on a more recent epidemiological knowledge, the weighting factors for the tissues have been changed, notably for gonads and breast. There have been relevant changes with respect to ICRP 60. Also remainder now has a higher contribution to the effective dose, and some new organs like brain or salivary glands now have been introduced with specific weighting factors. So only from this point of view, there is already the need to recalculate the dose coefficients, because the algorithm to calculate the effective dose is a little bit different. Then we have also the fact we took the opportunity to update the document, also to develop biokinetic models in form of compartmental structure in order to make it more similar to the approach that is used by ICRP for exposure of the workers, or exposures of members of the public. We also took into consideration, or we introduced the use of a dynamic bladder model to describe the urinary excretion. As you probably know, most radiopharmaceuticals are rapidly excreted in the urine, and urinary bladder may be, at least for some substances, the highest contributor to the effective dose. That's why it's important to have a realistic description of the dose to the bladder, and that's the reason we introduced the dynamic bladder model. We used the new adult and pediatric reference computational phantoms for the calculation of the doses to the organ. These are the reference phantoms which already Dietmar mentioned before, and they have been developed for reference individuals, male and female, and also children of different age groups. And finally, we also considered the updated nuclear decay data from publication 107. So all these new features have now been considered in the calculation of the dose coefficients, and you may understand that the contribution and the effect that they have on the calculation of the dose is a little bit complicated, because they contribute in different way to the calculation of the dose. As I said before, we moved to the use of compartmental models for the description of the biokinetics. Until now, for the vast majority of the radionuclides, the biokinetic was described by such tables. It was just a descriptive model where you had the fraction of activity which goes in the organ, and you have a retention time in that organ. The retention time may have more components, but as you see, there is actually no real connection between the organs in itself. So we moved to the use of a compartmental structure. As I said, it is a typical way of describing biokinetics, which is used in the publications for workers' exposures and exposures of members of the public. And we had two different approaches. On one, for some radiopharmaceuticals, we just translated the descriptive models into a compartmental structure, adding a blood compartment, because of course physiologically you have at the beginning the administration in blood, then from blood it is distributed to the different organs according to the values given in the table, and then from the organs goes back to the blood, and then is excreted mainly from the urine. You may have also some excretion through the alimentary tract, also through the intestine. And this is a very simple model. It's you have only one-way passage, so you have a passage from one compartment to the other without recycling. But still, it's important to have introduced the blood and to have introduced a general consistent description of the biokinetics. As I said, the transfer coefficients are calculated from the values presented in the table, and for the transfer rates out of blood, we just have some generic assumptions on the transfer rate of the retention in blood, the general assumption from ICRP, also from the other type of exposures, is to have a retention time of 0.25 hours. But if we have a specific value from the literature, we use that. The second approach that we use is to forget, let's say, the descriptive tables and then to develop on our own biokinetic models, like the one here that was developed by Alexandra, who will speak later on for FDG. This requires having good biokinetic data available for the development of the model, which is not often the case. But when it's the case, then it's possible to build a more realistic, physiologically realistic models with exchange between organs and blood, a clear description of the pathways. We also took some models which are already published in the literature, like the one here for fluorine choline that was developed in previous projects independently from the task group. There are also a couple of examples, like for pertechnetate or iodine, where we have already ICRP models, because pertechnetate and iodine are differently than most of the other radiopharmaceuticals, are injected without being linked to a specific molecule, so they follow the biokinetics, of the element. And so we have in the OAR publication, that is a publication for the exposure of workers, a very detailed model for technetium that is actually defined based on data for pertechnetate. And in this report, we have adopted the model from the OAR publication with a slight modification, because based on discussion with our medical members, liver is usually not seen in the images of the patients, so we have removed the liver compartment and we have distributed the activity in the liver to the other soft tissues. The same is done for iodine. We have a very specific and very detailed model for iodine in ICRP publication, both for members of the public and the workers. Actually, this model was already present in 128. It was, I may say, the exception in 128, because it was one of the few or the only real compartmental model. We made some slight changes to some of the assumptions that were used in 128. In 128, we have calculation for 3 different levels of uptake in the thyroid, and there is also a case which was called zero uptake, but actually it was referred to a blocked thyroid. So when iodide in the thyroid is not organized to organic iodine. So to be more specific, we have moved now to describe, to introduce 2 different situations, 2 different cases. One where there is no organification of the iodine, and we have called it blocked thyroid, and one where there is no uptake in the thyroid, like for example, in the case where thyroid has been removed after therapy. And so in that case, we really have no uptake in the thyroid, but we also have no thyroid, no tissue in the patient. And so we have to take this into account, removing the thyroid from the tissues which are part of the set of organs for which we calculate the dose. And also the description of the urinary excretion has been updated, taking into account, as we will see later, the dynamic bladder model. I don't say much about the dynamic bladder model because we will have a presentation later by Martin, just to know that with this we try to describe in a more realistic way both how the bladder is filled and emptied, how the activity changes in the bladder, but also considering geometric modification of the bladder, so also how the radiation dose is absorbed in the wall of the bladder, and all these aspects are taken into account to have a more realistic description of evaluation of the doses to the bladder. Dietmar has already mentioned before that those coefficients have been quite popular and have been used, and also for several assumptions on the risk. Here, I would like to make a little bit of warning about the use of effective dose in nuclear medicine, also referring to the specific ICRP publication on the dose quantities. Please, you have to remember that effective dose is a radiation protection quantity. Radiation protection quantity, it is based on reference values and is related to a reference person, not to a specific individual. I would say to a reference, non-existing reference person. And its main use is for making prospective dose assessment, for planning and optimization, or retrospective demonstration of compliance for regulatory purpose. Effective dose has been widely used in medical applications, sometimes as also misused. Therefore, I try to put here some boundaries. It's okay to have a effective dose as a generic indicator for classifying different types of medical procedures into broad risk categories. It's practical to compare doses related to stochastic effects from different examination, or when you use similar technology in different hospitals and countries, or when you use different alternative methodologies for the same medical examination. But you also have to take into account that the effective dose is always defined for the reference person. So you have also to take into account if your representative patient population is different when you make this comparison, that the comparison with the effective dose may not be relevant. And in that case, it may be more useful to use the organ doses, or even better, the dosimetric quantities that you get directly from, example, from the machines or from the activity in case of nuclear medicine. Nonetheless, also in our cases, we have some examples where the patient population also, it's not really well described by the reference person. For example, you have some radiopharmaceuticals which are administered only to patients of one sex only, or you have patients that have some anatomical or physiological differences from the reference patient. So in the document, we have also provided some estimation of a quantity. We didn't call it effective dose because it's not the effective dose as defined by ICRP, but it's calculated as if it were an effective dose. So if it's in the case of administration to patients of only one sex, we have considered only the sum of the effective dose for the organ doses in the patient of that sex, so only equivalent doses for female patient or for male patients, or in the case when we have abnormal masses of the organ, we have abnormal function of an organ like renal failure, or we have missing organs, as is the case I said before, the thyroid. We introduce this quantity where the calculation is like the effective dose, but it's not really the effective dose. And so in order to identify it, we identify it with this equation, and you will find these values in the tables in the document. An example here is for technetium MAG3, where we have the case of abnormal acute renal blockage. So we have that of the two kidneys, one kidney is functioning properly, the other not. So we have two different retention times in the kidney, which leads to two different doses for the two different kidneys, but not only for the kidneys, but also for the surrounding organs. And why it is important to calculate this alternative quantity to the effective dose is shown here. So if we calculate this alternative quantity, we consider that the difference, if the activity is located in the left or in the right kidney, and these tables give the dose, the equivalent dose to specific target region, to specific target tissues, and this is the ratio if the activity is in the left kidney or in the right kidney. And you see, for example, for the spleen, that is a ratio of 12, so there is a difference of a factor 12 whether the dose, the main activity is retained in the left or in the right kidney. On the contrary, other organs like the gallbladder or the liver, the dose will be about 1/4, 1/5 if the activity is in the left kidney with respect to the activity in the right kidney. So just here a little bit of some sneaking preview of what you will find in the document. As mentioned, or as Dietmar already mentioned, the models that we have developed here, and in this document now we have the models for nearly 30 radiopharmaceuticals, so there will be other models for other pharmaceuticals that will be issued later. These models will also need to be adapted in order to consider application during pregnancy and breastfeeding. At the moment, ICRP has only one publication for doses to infants for ingestion of radionuclides from mother's milk, but this is a general publication and there are no specific information for radiopharmaceuticals. What the new task group that Dietmar mentioned, task group 130, is going to do is to take the models that have been developed and will be developed from task group 36 and update it or modify it properly as are needed, taking into account the changes that occurs during pregnancy and breastfeeding, and including, of course, the transfer of material from the maternal to the fetal tissues, and also to consider the fetal and pediatric dose coefficients that will be calculated using the new reference computational models from the children, but also from the pregnant adult and from the fetus that are being developed by task group 96 and 103. And in this instance, just the last comment is that in the case of pregnancy, not only is important to consider the dose coming from the milk of the mother, but also to consider the dose coming from the activity in the body of the mother. And here I just would like to mention a possible cooperation with the joint task group of Urados and EINM that make this kind of calculation, including the biokinetic models, so have a real biokinetic activity in the patients, in this case of the mother, and to make Monte Carlo simulation depicting a real exposure situation. In this case, will be the situation of the child, which is in the arms of the mother. So this will be a possible future work that will be done by the continuation of the task group. And I thank you for your attention, and I would like to give now the floor to Martin for the rest of for the next presentation.
Thank you so much, Augusto. So, but I will talk about the special case, the dynamic bladder model. And the reason for this is that many radiopharmaceuticals have a high excretion for urine. And in publication 128, 7 of 60 models had the urinary bladder wall contributed with more than 50% of the total dose to effective dose. And this is also a tissue radiation factor of 0.04. So for radiopharmaceuticals, a lot of excretion goes through the urinary bladder, and a lot of dose comes to the bladder wall. So the changes from the previous publication, where we had a static urinary bladder of 200 milliliter, we now have a dynamic shape of the bladder from different sizes, from 10 to 500 milliliters. We had a static SAF value, meaning it was constant regardless how much activity there was in the bladder in the model. So now we also have that the SAF value changes with the bladder volume. So if the bladder is 300 milliliter, it has one SAF value, and if it has 100, it has another SAF value. So we also include the self-absorption in this. We had in the 128 fixed ages, so we had a time period for different ages. Now we change this to voiding interval, so we have biological parameters. So once it comes up to a volume, which it can set to an excretion rate, then this one is excreted. And this also now implemented this in the compartmental models. So these calculations are fully incorporated in the compartmental models. And this is not the first time people have made a dynamic bladder. So the first model came from Cloutier in 1973, where he investigated the dose to fetus from the urinary bladder. And then it went on, and Snyder and Ford did one where they calculated absorbed dose to urinary wall. And then Thomas, he also included the surface of the wall. So there has been, over the years, different dynamic models. And our biodynamic model is based on biological parameters, which you all can find in the ICRP publication 89. And we use their excretion rate, initial volume, voiding volume, and residual volume. And also in this, you have the daily urine excretions per day. So this is what we assume to be the normal excretion rate from the body. And we will also have it, you can have high excretion if you have, like for FTG, if you drink water before, you can also include this. And as I said, in the previous one, you had set times for different intervals in the calculations. And also to make this SAF values dynamic, we took the anatomical data from ICRP 89 to the mass of the urinary wall. We took the elemental composition from the ICRP publication 110, and we did, as the other SAF values used in the calculation, we did it monoenergetic for alpha, betas, and gammas, and we did this from 0.001 to 10 MeV, and we did this for 26 spherical volumes, and also 7 different anatomical regions. So in total, we made 15,687 simulations. And to validate this simulation, we took the 200 milliliter bladder and compare it with the reference phantoms. So here you see our 200 milliliters and the SAF values for the reference adult phantoms. And for photon and electrons, you see that these values compare. So they are inagreeable. And then we added on 26 different other volumes, which we interpolate between. So we interpolate between SAF values, which are monoenergetic, and also between the volumes, which are kept by knowing the excretion rate and parameters, initial parameters in the bladder. And why we do this is that then we can simulate. So this is the FTG model made by Alexandra, who will talk after me. And where you see we can fit data both on non-voiding patients, and also here we have patients from Malmö where they excreted after 45 minutes. So we can start combining these two models and also get a more accurate biological representation of the urine in the body. And as Augusto told you, so we have 3 different parameters going on. We have the urinary bladder volume. We have the excretion. So in the middle, you see here, the red line is if we had no excretion, but then we had one after 1 hour, and it goes down, and it starts a new one. And also combining this with the SAF values to the bladder. So in this case, we think this is a more accurate prediction of the dose to the urinary wall. So that's what I was talking about, the urinary wall. I will also talk about, to this publication, we will have supplementary data. So you will have one electronic set where you can extract the data if you want from the publication, but we will also have an ICRP dose viewer app. This is because, as you see, as Dietmar told us, we have a lot of revisions and new models coming up, and instead of always having them on print, then we could have them on an app and directly upload them, so they will be available and people don't have to keep track of different addendums coming in. So I will first go through the supplemental material. So once this publication is published, it will come to the ICOP webpage, and then you will have a supplemental link, which will be a CVS file. And in this file, you will get the biogenetic models used in the calculations. You will have the time integrated activity coefficients, the TIACs, and also the absorbed dose and effective dose. And I will just shortly show the structure of this file. So first, you will have a general structure where you have, if you see here of the FTD, it says 21, 13, and 1. So this will be, the 21 will be the number of transfer rates used in this biogenetic model. 13 will be the number of compartments, and the Z will be the number of cases we have considered for ages. Sometimes we will have age-specific biogenetic models, and sometimes you only have the adults. It depends on how much data we had when we were generating the model. And by structuring this way, it's also possible for users to extract this through code if you want to do, because it will be a long file. It will be maybe 3,000 rows or something. So it is a way also to extract it for users to have this data and use it. So after the biogenetic model, you have the TIACs, so we come the source. This is for FTG, and you will also have the urinary bladder, where it's based on different ages. And finally, you will also get the absorbed doses for all ages. And we will have here, in the last one, infant. So the phantom are from 0 to 1 year, but the ICP gives a representative date of an infant, which is 100 days. And then you will have at the bottom the effective dose as given in 103. So this hopefully helps the community to use the data. And to this also, we have created an ICP dose viewer app. So all of this data, which are shown in the file, will also be uploaded to this app, which you can currently also now, it's ready, but it's still for 128. So it's not, the data coefficients will be updated first once the publication is released, but currently we have it for 128. And you can download it through iPhone and Android. Currently the Android version is a little bit down, but it will be up again in 2 weeks. There's some new regulations I have to agree on. But it looks like this. So you have here, we also put in from other task group intake. So we have also members of the public and occupational intake. We will also include X-ray intake once that is published. So once the publication is out, it will, the diagnostic nuclear medicine will go down to the effective dose of 103. And its plan is to just easily to manage and get an effective dose. So you just select element, then you select which pharmaceutical you want from that element, and you select which age you want to show absorbed dose and effective dose from. And then you get this dose coefficient. So when you make these 3 sections, you have a dose coefficient. And we also added, if you want to add administration on this, you can then also put on, like if you want to know the absorbed dose, effective dose for 350 megabecquerel administration, then afterwards this effective dose comes out, and you also get the absorbed doses for this case. And here is just adult, but then in the future you will have organ doses for both male and female. And so this is for what we hope is an easy and quick way to just get you a feeling of an effective dose for a representative case. And the app is available now on App Store and Google Play. So that's what I was planning to talk about. And I leave it back to Alexandra.
Okay, thank you, Martin. Hello, everyone. Let's now look at the differences between the revised dose coefficients and the previously published ones. There are different factors that cause the changes in those coefficients, and Augusto talked about this already in his presentation, so I will not go into the details here. But just to remind you, I highlighted here the main features that contributed to the differences. So it is the move from the descriptive to compartmental biokinetic models that describe the distribution and the excretion of radiopharmaceuticals in a physiologically more realistic way. That's the use of the dynamic bladder model that Martin just talked about, the use of the human elementary tract model of the publication 100 to describe the excretion via the elementary tract. And then the use of reference anthropomorphic phantoms and then USAFs that are reported in the publications listed here for all age groups. And also the weighting factors and the definition of the effective dose of the publication 103. So these are the features that were common for all the substances that we considered. And there were also some special cases, for example, how we model the blocked or saturated thyroid after an administration of iodide, and Augusto talked about this already, or a case of an intratumoral injection of technetium-labeled small colloids. I will come back to this example a little bit later. So as you can see, there's a whole combination of factors that cause the differences. Now, let's look more specifically at the coefficients of the effective dose. I plotted effective dose coefficients here on the y-axis for various radiopharmaceuticals that are listed here along the x-axis. The red crosses here represent the revised effective dose coefficients, so from the new report, and the black squares are those of the publication 128. So if you look here at the upper part of the plot, you can see their percent differences of their revised coefficients relative to those of the publication 128. So we do not have time to look at each of these radiopharmaceuticals specifically, but let's focus on those where the differences were substantial. So the first one is intravenous injection of technetium-labeled pertechnetat in the case when the thyroid blocking agent was given. Publication 128 assumed for this case that the technetium activity was homogeneously distributed in the body. So the total body was a source region here. And we used in our biokinetic description a more realistic biokinetics to describe the distribution and the excretion of pertechnetat, and this was the main reason of the observed differences. Then technetium label Mark III in the case of normal renal function. In this case, the effective dose coefficient appeared to become lower than the one of the publication 128. And the main reason for that was the use of the dynamic bladder model in a combination of earlier time of the first voiding. So we also applied in our calculations realistic voiding regimes as it is used in clinics. And we actually did it for other substances as well. But in the case of Mark III, the absorbed dose of the urinary bladder wall was notably higher compared to other organ doses. So its impact on the change on the effective dose was substantial. And the last case, which I already mentioned, it's an intratumoral injection of technetium-labeled small colloids. Publication 128 assumed in this case that technetium activity was homogeneously distributed in both breasts. The activity actually almost solely remains within the tumor, and tumor is a source region in this case that irradiates the healthy breast and other body organs and tissues, and we modeled this in this way. So we did some additional calculations to compute their SF values for tumor as a source. I also tried to identify some main trends in the changes, and I find 2 target regions interesting. The first one is the red bone marrow, and here I plotted the absorbed organ dose coefficients for bone marrow. So how you should interpret this plot. Here you can see the absorbed dose coefficients for bone marrow from the revised report plotted against the values of the publication 128. This middle line corresponds to the case when the coefficients were the same. The revised coefficients were exactly the same as the previously published ones. So each point here is a single radiopharmaceutical. So everything that lies above this middle line corresponds to the case when their revised dose coefficients became larger than the ones of the publication 128, and everything that is below the line corresponds to the case when they became smaller. And as you can see, in the case of red bone marrow, for almost all radiopharmaceuticals, the absorbed organ dose coefficients became larger, and this was due to the fact that we considered blood as an explicit source region in our calculations. This observation was valid for all age groups, and here you can see a similar plot for 1-year-olds, and you also can see that the revised dose coefficients for bone marrow are larger than their previous ones. In the case of a urinary bladder wall, you can see similar plot, but the situation was quite the opposite. And you can see here that the revised absorbed organ dose coefficient for urinary bladder wall actually became smaller now compared to the ones of the publication 128. And the reason for that was the main reason for that was the use of the dynamic bladder model in a combination of earlier times of the first voidings. Again, it was the same for other age groups as well. Here you can see the 1-year-olds. But if you look at the effective dose, here is a similar plot for the effective dose. Again, this middle line, and each point here represents one radiopharmaceutical. You can see that we do not observe such trend as in the case of the red bone marrow or urinary bladder wall. And so some revised effective dose coefficients became a little bit larger, others became smaller compared to the publication 128. But actually all of them lie pretty well along this middle line. Again, it was similar for all age groups. Here you can see the plot for 1-year-old. Okay, this is what I wanted to show you today, and I thank you for your attention.
Yes, and I'm Keon, and I'd like to discuss about the future trends and the applications in diagnostic nuclear medicine in the point of view and from the nuclear medicine physicians. I prepared this presentation with Makoto Sono. And we have our next generation imaging systems, and also AR is introduced in the reconstructions of imaging right now. And so total body PET, half body PET is covering more than 1 meters and extra field of view, dramatically increasing sensitivities of the PET counts and from the body, and so up to 40%, 40 times. And it means that we can inject less than 1 millicurie can be imaged, and so the effective dose is less than 1 millisievert can be achieved, and also we can have a faster scans. And another new system will be deep learning and the CT reconstructions using artificial intelligence, and also photon counting and CT can be also reduce the dose of from the CT, and just around the 30 to 70% of those reduction can be possible. And next. And so the new nuclear medicine imaging for the clinical decision making and individual treatment is available, especially for oncology, and the PSMA is widely available right now. But in the PSMA can also detect oligometastasis as well. And so it enables metastatic directed external beam radiotherapy, so improve the patient prognosis. And for breast cancers, and the FES PET is available, is visualized ER estrogen receptor positive regions, and also it guides the hormone therapy or local treatment. It improves as patient prognosis as well. Also, gallium or F18 PARP PAN, and available for imaging of the inflammations or various tumors. And for the cardiology, for Peridar's PAD is available right now, and for the myocardial perfusions. And traditionally, we use a technetium-based system, maybe, or something like that for SPECT imaging. But in the new PAD is available right now, as it also improves the coronary artery disease. Also, it reduces those as well. For the neurology, amyloid PET is now very popular, and for Alzheimer's disease detections, as well as there are new anti-amyloid therapies available using the anti-amyloid antibodies as well available. So, and it dramatically increased the need of the amyloid PET and for screening and follow-up. And tau PET is now in some countries is available already in the registered drugs, and for tau imaging in Alzheimer's disease. It sparks a tau positive patient, and it enhanced the development of therapies such as anti-tau drugs. This is the final slide for me, and there's new novel radionuclide therapies coming out, and so many of them is under clinical trial, and so it also co-developing the companion diagnostic as well. So these new and the imaging modality, imaging new radiopharmaceutical will be coming out in the clinic. And one of the examples in dotatate and active dotatate is now on the clinical trial as a lutetium dotatate is already commercially available in many countries. So gallium somatostatin receptor 2 imaging, such as dotatate imaging or dotatug imaging, is used for a companion diagnostic, selecting the patient for this kind of treatment. Also, PSMA treatment is widely available right now, and so we need a screening test, and the PSMA path is needed. CA9 is targeting to the small renal cell carcinoma, is now on the clinical trial right now, and so it is developing as a form of the antibody. And the antibody has a very long half-life, and so zirconium-89 is well matched because it is a long half-life, and such zirconium-89 girentuximab targeting to CA9 PET is on the clinical trial as a companion diagnostics. Recently, DLL3 targeting and their theranostics is on the clinical trial by Novartis, and so actinium-based one, DLL3 is overexpressed in the for neuroendocrine carcinomas, neuroendocrine, and differentiated prostatic cancers and small cell lung cancers. Also, ENT29 SPECT, indium-based one, is co-developing as a companion diagnostics. NEO-B is targeting for is a GLPR agonist, and so it is targeting for breast cancers as a GI tumors. So gallium NEO-B path is a companion diagnostics, and so many of the new radiopharmaceuticals for diagnostic imaging is under clinical trial. Will be coming out and in the clinic in the near future. Thank you.
Okay, so thank you very much, Keon. So now we have completed the part on the presentation of the document, and in this second part of the workshop we have organized a roundtable with representatives of some of the most relevant stakeholders in the field of nuclear medicine. We know that ICRP models and those coefficients are widely used. During this discussion, I would like to understand more what are the general expectations and wishes of the stakeholders regarding the ICRP activities in the field of nuclear medicine, not necessarily only on the dosimetric, on the diagnostic, those coefficients, to see if there are some topics that can be identified of mutual interest, the potential of improvement, of collaboration, and so on. Some of the challenges we have heard during the presentation, especially now in the last presentation by Keon, we have heard some of the recent challenges, and now I would like to welcome the guests to our round table. I ask you if you can turn your video on, and I would like to introduce you. So I will start in plain alphabetical order. I will start with David Broggio, which is from the French Authority of Nuclear Safety and Radiation Protection, and is representing EURADOS here, the European Radiation Dosimetry Group. Then we have Vesna Gershon from the she's a radiation protection specialist from the Division of Radiation Transport and Waste Safety from the International Atomic Energy Agency. I have some feedback. We have, thank you, we have Byung-Il Kim from the Korean Institute of Radiological and Medical Sciences. He is chair of the Radiation Safety Committee of the Korean Society of Nuclear Medicine. Jens Kurt from the University of Rostock in Germany is representing the European Association of Nuclear Medicine. He is the chair of the Radiation Protection Committee. And we have Pat Zanzonico from the Department of Medical Physics of the Memorial Sloan Kettering Cancer Center and chair of the MIRD Committee in representation of the Society of Nuclear Medicine and Nuclear Medicine. We also had Eric Mora Ramirez from the University of Costa Rica, but I don't see him in the list of participants. Maybe he will join later. So so first of all, thank you very much, all of you, for being here, for being available for this discussion. And I would like to start the discussion with Vesna, with the international agency. We would like to hear from you about the current activity and interest of the agency in the field of nuclear medicine. Just to remind that recently, in end of April, there was a very interesting technical meeting on radiation protection challenges in modern nuclear medicine in Vienna, hosted by you. So what are your perspectives, your ideas, your interests, your suggestions for ICRP?
Thank you, Augusto. Regards from Vienna. Good afternoon, good morning. First of all, I would like to say congratulations to our ICRP colleagues for developing this publication. And as usual, it is, once it's officially published, we will promote it in our materials and publications. And before starting with our further activities, I would like to mention that the number of examinations in nuclear medicine is increasing daily, with a large variety of the types of examinations, and then we have situations with multiple procedures in the same patient, etc. So radiation protection of patients in nuclear medicine is getting more and more important. And IA is aware of the lack of patient dose assessment, regular patient dose assessment in the diagnostic nuclear medicine practice, and particularly in developing countries. And without a regular and accurate assessment of the patient doses, we practically cannot effectively implement the principles of radiation protection of patients. And there are two major issues. Here, the lack of human capacities. For example, even there are nuclear medicine facilities without involvement of qualified medical physicists. And the second one is the lack of available dose assessment tools and softwares across these nuclear medicine facilities in the member states. I put a lot of efforts in addressing these gaps. For example, very soon, in the following months, the IA will launch a global survey on existing practice in diagnostic and therapy nuclear medicine in the member states, with a particular aspect of assessing the status of patient dose assessment and monitoring practice of the patient dose. And based on these findings from this survey, we will develop short and medium-term action plans for the further IA activities related to radiation protection of the patients. And also, we are ready to support and contribute to any activities on establishing diagnostic reference levels in the hybrid component of the systems. And we will join any regional or global initiative related to these activities.
Thank you very much, Vesna. I move now to Pat Zanzonico. Mir, you know,
Yes.
we know is the institute who sets the rules of the game for radiopharmaceuticals dosimetry. Now there is a lot of new software that has been published on your platform, on your webpage, midsoft.org, and I invite all the participants also to look there, where you have a lot of useful and very practical material for those calculations. How is, in your opinion, what are, as I said, the challenges? Of course, the therapeutic part of nuclear medicine, which is now exploding, is a big issue. However, I personally think that in that case, it is difficult to have some kind of reference models or general models as we have from ICRP. But what can be the challenges that can be, so to say, addressed together? I stopped my microphone because it started raining very, very strong here. Probably you.
Well, hello, everyone. I want to thank you for the opportunity to contribute, and I also want to add my congratulations to the ICRP and the task force members and all the presenters. It's really outstanding work that's importantly advancing the field of radiopharmaceutical dosimetry. And as Augusto said, the MERD committee at the present time is really pursuing the development and dissemination of free but vetted, that is peer-reviewed software for radiopharmaceutical dosimetry. Sort of the cornerstone piece of software is MERD Calc, which is basically an organ-level dosimetry algorithm. It's basically a computerized version of the MERD formalism. There are additional components of MERD Soft, all of which are freely downloadable and accessible on merdsoft.org, all of which are peer-reviewed and so forth. These include MERD Fit, a curve fitting program with error propagation for biokinetic data. There's MERD CT, which will be published shortly, which will include dosimetry for the CT component of hybrid studies such as PET CT and SPECT CT, and also diagnostic quality CT scans. We'll be publishing a piece of software called MERD Release, which will evaluate doses to individuals around radiopharmaceutical therapy patients and provide guidance calculations for releasability of therapy patients and the duration of post-release precautions. We'll also be developing what we call MERD 3D, which will be a freely downloadable voxel level dosimetry, again, adaptable to radiopharmaceutical therapy. So, and several years ago, we had published the MERD Primer 2022, which was basically an introductory text, an educational text, as its name implies, for radiopharmaceutical dosimetry. So, I think several key initiatives I think that the ICRP is publishing or pursuing, and that we're certainly endorsing, is guidance for related to breastfeeding, nursing, and so forth. I think that's an important, very important consideration, because I think increasingly women of childbearing age and of an age having young children and so forth are increasingly undergoing nuclear medicine procedures. So I think that's going to be an increasingly high profile issue, and I think that's an important issue to pursue. A second issue, I think, is we all recognize PET is done exclusively as a hybrid imaging modality, PET-CT, and increasingly SPECT as well is being done as a hybrid modality as SPECT-CT. And in many of these instances, the CT dose component or contribution is greater than that of the radiopharmaceutical component. So I think including some estimate of the CT dose contribution in these hybrid imaging modalities is going to be increasingly important. And as I mentioned, that's one of the reasons why the MERD committee is pursuing MERD CT to provide dose estimates of CT components based on actual measurements of the dose length product and other dosimetric parameters of actual CT scan is used in the field. And that is going to be based on a mesh anatomic model rather than the voxel level model. And I think that'll ultimately be a significant advance, not only in the CT dosimetry, of course, but also in radiopharmaceutical dosimetry. I think those are several areas where I would encourage the ICRP to invest time and effort. Dosimetry for the CT component of hybrid imaging studies, dosimetry related to breastfeeding, and adaptation increasingly of mesh-based model anatomic models as opposed to voxel level models. But again, I really want to congratulate the ICRP and the task force for really the very high quality and important work that they're performing.
Thank you. Thank you for your considerations. We didn't have time now to present all the things that are in the document, but in the document we have also at the moment some recommendations, for at least recommendations for breastfeedings, and some general recommendation also in the case of extravasation, sorry. As Dietmar also mentioned, and I mentioned, the next work for the new task group will be the doses for breastfeedings and pregnant patients. And in this case, if I'm not wrong, the new voxel, the new phantoms, reference phantoms for ICRP for the pregnant female and for the fetus are already mesh phantoms. Now for this publication, we were a little bit linked to use the formulation of ICRP 103. But all of these things are very useful. Also, the part on the CT part of the hybrid imaging. There is another task group in ICRP who is doing those coefficients for external for X-ray applications, including CT. So we didn't include here particularly the part on the CT contribution. When I was at the workshop in Vienna last April, I learned about this trend that may be also very interesting from the radiation point of view, of the use of artificial intelligence information in order to make kind of CT-free hybrid imaging, making use of all the or other already available imaging, which would be for me really a good breakthrough with respect to improving the dosimetry in due to the CT. And then maybe I would like to shift to go to the other part of the ocean, to our Korean colleague, and to ask him about this part of these aspects, like what are the implication of the use of artificial intelligence and other new aspects that you think are useful from the radiation protection point of view.
Thank you, Chairman. And about artificial intelligence, this is not easy to speak right now. And as a nuclear medicine physician perspective, I would like to give us three topics of relating today's discussion. Yes. First, I want to express my sincere thanks to the task group. I think this work is highly detailed and practical, and creating new and realistic dose coefficient is not easy. And I believe many people in our field will benefit from this effort. As a member of Korean Society of Nuclear Medicine, I truly appreciate your work. Once the data was finalized, I hope to introduce this valuable information to the members of Korean Society of Nuclear Medicine through the web page of the radiation safety community on the Korean Society of Nuclear Medicine. And in this context, if we wish to summarize and share the reports in Korean language for the benefit of our members, we believe that providing a translated overview would not cause any major risk of misinformation. So, does the ICRP have a flexible policy regarding such translations, or would prior approval be required? Is there any problem?
It's okay now. There was some interference before, but I think it's okay now.
Yes. Yes. Let me talk my second issue. Yeah. And second, I found the improved dose coefficients for the F18 FDC Bladder were very meaningful. The use of a dynamic Bladder model reflects the real patient situation more accurately and have reduced uncertainty in effective dose. However, in Korea, Tecushin 19M phosphonates are still widely used for bone scan. I could not find their dose coefficient in this draft. If they are included and I missed them, please kindly let me know. Otherwise, I hope they will be added in the final version or near future. And third, I have a question regarding the use of reference phantoms. I understand the reports is based on ICRP voxel type phantoms. In Korea, there may be a voxel or mesh phantoms that better represents the Korean population. If so, I wonder whether using such local phantom could help further refine those coefficients. What is the ICRP's general stance on using localized phantom to calculate population-specific dose coefficients? If collaborative research or some forms of ICRP approval process is needed for this, I'd appreciate any additional information. These are my points I want to share. Thank you very much.
Thank you very much for your points regarding the radiopharmaceuticals. You're right, there will be models for other radiopharmaceuticals which are not included now in the draft, but they will be included either in the revised version of the draft or in a future publication. We are working on that. About the so to say, regional reference individuals. At the moment, ICRP, so this is my understanding of the ICRP position. At the moment, ICRP has this reference person, which is taken to be representatives. So the reference person for ICRP. I know that also in other fields, in other applications, there are different reference persons which have been defined for the Asian people, for example, in occupational or in exposure of the public. And personally, I think that this is a good opportunity. So we have in our publication, we have the general information about what is biokinetics and the main physiological information, and you can combine it with your regional reference person. Of course, if you want to go more in detail, you can also consider if there are differences also in the biokinetics. This is typical, for example, and for the population on the iodine, where some regional differences, where you have people living in more rich or more poor iodine regions. But of course, I think this is also an aspect that will be discussed. You probably know ICRP is now going over a period of revising the recommendation. We have this period that will be concluded in some 5-7 years, I don't know, with new recommendations. So there are at the moment also many task groups within ICRP which are discussing many aspects, how the recommendation can be improved. And I expect that also this issue of the reference populations is one of that it is discussed. I hope that it was a good enough answer to your question.
Thank you very much.
Yeah, thank you for your participation. I see that now also Eric Mora Ramirez is here, so welcome. And so I just make you my question about expectations and maybe status of nuclear medicine, diagnostic, dosimetry, internal dosimetry for nuclear medical and diagnostic in Latin America. You have some specific requests, specific recommendations, specific requirements from the ICRP.
Hi, good morning. I think that specifically for this ICRP, I think that this is a very interesting document because it's an update of information. Maybe there are a few things that are missing, but I think in Latin America we are trying to develop more and more dosimetry because we are now more medical physicists in clinics, and I think that especially for therapy, we have more understanding, and we are working with physicians as well. So I think that in few years' time, we will have a good base in order to provide information for institutions like ICRP, because for some therapies, specifically for lutetium, we are trying to work together. We are trying to have more workstations in order to perform dosimetry. We're trying to have more equipment, more phantoms, and I think that this type of document will help us somehow in order to provide the best information for the physicians. Then I think that we are going to be working. We are trying in the region, trying to provide guidelines for young physicists, trying to provide courses. We're trying to provide a lot of information for clinics in which they wanted to provide or services, for instance, therapy. I think that's it. I cannot hear you, Augusto.
Sorry, I was muted. Thank you very much, Eric. The issue of the dosimetry for therapy is a little bit, for me, controversial, because it's possible for me in the dosimetry for the diagnostic nuclear medicine to have some reference models and some reference dose coefficients. In the case of therapy, you really need individual dosimetry. So what ICRP can do, as it did in publication 140, is to give some general recommendation from the radiation protection view. But I think in the case of dosimetry, it's more the medical societies or the professional societies, which are on one side closer to the patients. They have also, let's say, also a reaction time which is faster than the one of ICRP. So I think in the case of therapy, ICRP can set the framework, but the work must be more done on the local level. So let's go back to Europe now, and let's hear from Jens from the Committee of European Association of Nuclear Medicine.
Thank you very much. First, I would congratulate all the contributors as well for the fantastic work and for the finalization of the upcoming document and the data. I have just learned that task group 36 is going to disappear, so I would also like to thank for the outstanding work over decades. So it's an amazing work. And as Professor Kang already highlighted in his talk, we are seeing an enormous increase in nuclear medicine procedures, especially of therapies, and a growing number of radiopharmaceuticals. And in this context, there are various aspects of radiation protection that are important for clinical implementation. On the one hand, it has already been mentioned, the issue of dosimetry, which has been addressed by the ICRP in publication 140, but we are also concerned with the issue of patient release, which patients need to be hospitalized, which do not. We need guidelines here in order to achieve some kind of harmonization, and this also avoid possible bottlenecks in terms of accessibility to the therapies. The ENM is working on recommendations together with HERCAR and Eurodov, but I think future collaborations with ICRP and also IAEA is surely advised to provide some guidance on a global level as well. And another important topic with the increase in therapies, the issue of the proper application of the therapeutic agents, and also is coming into the focus. And in the interest of standardization, we certainly need valid information on how to ensure a safe administration, but also on what to do in the event of an extravasation. And this also includes the topic of some kind of guideline on how dosimetric assessment in can be made in the event of an extravasation in order to derive further medical steps if necessary. ENM is working on this topic together with Eurados, but we definitely need more data, especially for a valid dosimetry.
Thank you. I don't know if Makoto is here from Committee 3 and he wants to say something about future work of the Commission in the case of therapy, like Jens now told also the aspects of the release of patients.
Yeah, thanks, Augusto. Yes, as a nuclear medicine physician, I really think that the individualized dosimetry will be necessary. And I think we already started to work on some individualized dosimetry, and nowadays are commercially available individualized dosimetric method are used in the clinical settings, and also such our international framework between our EANM and the other academic societies will promote the facilitation of such effort of constructing individual dosimetry. And the future application of our therapeutic radiopharmaceuticals, such consideration of individualization will be an indispensable part of clinical practices. So I think such our international framework of collaboration will be very fruitful. Thank you so much.
Thank you, Makoto. And now we go to Eurados. David, Jens has already mentioned that there are some fruitful collaboration between the dosimetry and radiation protection committees of EANM and Eurados. I have also mentioned this possibility of application of some work which is done in Eurados for the future work on breastfeeding patients. Do you have other comments, consideration, suggestions for ICRP?
Yes, thank you, Augusto. I have some comments, and first of all, I must say that as a member of Eurados and as a professional of working at the French authority, we are very positive about the work of the task group and the update of the dose coefficients, because sometimes we must give advice to professionals, for example, in case of misadministration of radiopharmaceutical, and it is important that we can give the most up-to-date dose assessments. I am very positive also about the introduction of biokinetic model in this ICRP report, because it gives consistency with the other ICRP reports, and I think it paves the way for improvement of the models, because now that we have the models, we can compare to clinical data and potentially improve or modify the model in case of need. And regarding the needs or the challenge, I think one important thing is the personalization of the dosimetry in case of therapy. Maybe not full personalization, but at least improvement of the current prescription. And maybe it's not the role of ICRP to go in this direction, but if we add models, biokinetics models, for example, for gallium 68 PSMA, it could be helpful. It will be a basic model that could be adapted to therapy or that could help in the therapy case. So maybe ICRP and the professional society, they could work together, because there is a lot of experience on the side of ICRP, and the biokinetic model, I really think it could be useful for therapy, even if they are developed first for example, the gallium PSMA. Second, we are also concerned with the radio protection of the public, and we are also interested by the release criteria for the patient who are going to the therapy. And I think it is important that in Europe, we harmonize the practice and that they stand on a solid ground. And I think it's not only the question of the release criteria, but also the advice to the patient, what we have to tell to the patients, how we explain, for example, the contact restriction time. So I think here also there is a common work to be done between, for example, ICRP, the professional society, and the authorities, so that we have a global framework to go from the measurement at the hospital to the advice to the patient.
Okay, thank you very much. Very good number of very interesting inputs, which I hope that through this roundtable also arrives to the ICRP secretary, so they can put it in the list of the future work regarding the recommendation on the case of external release, for example. This would be, of course, a very good application of the new models, also in the case of workers' exposure. At the moment, the task of ICRP 36 was on developing the dose coefficients for the patients, but we think that the models that we are developing and we have published then can be applied also in several other ways, and not only necessarily from ICRP task groups, as you said. By the way of this collaboration, we can find a very good application of these models in all these description, including also the definition of the release of patients. I'm sorry that I have to stop here now the discussion. I just make a short round. If you have something else you want to add at the end of this round table.
Yes, Augusto, this is Pat Senzonico, and it was mentioned by another discussant, but I think it's worth emphasizing some consideration of uncertainty in dose estimation. We all, I think, implicitly use these dose estimates and dose coefficients as if they were perfectly accurate, even though, of course, we know they're not. And making that explicit in the ICRP publications, I think would be valuable.
We have actually a chapter about uncertainty, but is a little bit, so to say, general about the sources of uncertainty in the biokinetics and the dosimetric models. And I agree with you, and also the importance of the uncertainty is also to make the people aware to which level of individualization we really need to go, because it's not necessary to go too deep in the individualization when we have some uncertainties in the dose coefficients, or even worse in the risk coefficients that we are going to apply. Thank you very much. It's a very good opinion, a very good suggestion. And if everybody, if there is no other very, very urgent thing, I would like to thank you very, very much again. It was for me very interesting and very useful roundtable. I hope for the participants as well. And then I move back to Sigrid for the last part for the Q&A session.
Thank you very much, Augusto, and thank you all the members of the panelists. I think it was very interesting. We have had a lot of questions in the Q&A box. There are several of them that has already been answered directly from the speakers. I have some of them that is not well yet answered, but that is an important question also from Michael Lassman, who says, for pediatric nuclear medicine, how did you verify the compartment models as there are only varied data with a low number of patients available? And I would expect a quite time activity curves compared to adults. And I think also this is in conjunction with telling you how we get the information, the biokinetic data overall to this. And maybe, Augusto, you can answer this. How did we got all the data and how did we got especially for the pediatric?
It's a very good question, and it's so to say an historical issue from the task group, the lack of reliable data to develop the models, and of course this lack of data is more evident in the case of pediatric patients for a number of reasons which are understandable to everyone. There are not as many examinations as for the adults on one side. You have the very different age groups, so the number of data that you can have for age group is also limited. You cannot maybe take too many measurements in the pediatric patients. We can say from the experience we had for the FDG, where we have especially Alexandra and Martin have worked with it, and we had some data. Fortunately, we had also some data which were generated in the frame of the project. However, it was really difficult to make this data not available, but to use this data in a mode that was useful and was scientifically sound, to have a good biokinetic model specifically for patients. So the general answer to Michael's question is, our desire would be to have also biokinetic models that are age dependent. At the moment, we were not able to obtain all the information to have it for FDG, but also for the other substances, to have sufficiently good data to justify a specific model with age dependence for the biokinetics. So at the moment, the main source of the age dependency is the dosimetric part in the phantoms, which are, of course, in that case, they are age specific.
Yes.
I don't know if you, Sigrid, or Alexandra, or someone else wants to add something to this question.
No, I think it's a good answer. And then, as Michael Lassman said, it's difficult, and as you say also, Augusto, it's difficult to get this kind of information, the biokinetics for children, because when you're getting the information, you have to take a lot of scans after the radiopharmaceutical has been administered, and you don't want to do that on kids or small children. But I think it's very good if you can do it. But otherwise, often it's my experience that the dynamics is the biokinetic and the dynamics is more rapid in a small child than in an adult, which means that maybe we are over or exaggerating or over, get higher doses than actually should be. And I think that is better to have too high doses than the reality, than if it was on the reverse.
Maybe I can connect here to another question that there was in the Q&A regarding the use of AI. And so it was, at the moment, we didn't consider the use of AI in the development of our models, but it might be, I think, one possible way to consider some of the techniques of the artificial intelligence techniques maybe to be helpful to contribute to develop models in the cases as ours where the available data are not that sufficient. So it might be one possible solution that could be investigated in the future work of whichever task group will make the new models.
Yes, very good. And then I saw in the Q&A box that there is some questions, quite many, about the therapy and therapeutic substances. And I think we have dealt with that a lot. We have had this, so we can just point out that this is for diagnostic radiopharmaceuticals, and we have a little chapter on this also, why it's not for therapeutic substances in the draft, in the document. And then there was some questions also, and there was more comments and questions if it was very good presentations and that the people wanted to have them if they were possible to get the presentations. And yes, they will be on the ICRP website afterwards. Maybe some of them is changed a little bit. The presentations, the speakers will send them in also to the ICRP, so you will get this, the possibility. And then maybe we don't have so much left of the time. I can see.
I think we can also answer some of the question later. I think they will be put on the ICRP web page. So you will, as I understand, there will be a page with the registration of the session, and also you will find there the questions and the answer of the question that were put in the chat, in the Q&A chat.
Yes. Yes, it is. So actually, I think I will end this now. It's 1 minute left. Do you have anything left to say, Augusto?
Yeah, I wanted to say that you have seen some of the members of the task group here, but of course the task group was much larger. It was shown by Dietmar, all the people that contributed to this work, and I would like to thank all of them for their contribution, for their continuous contribution until now, and I hope also they will contribute also in the future for the new models and the new tasks that we have in front of us with lactation, with the breastfeeding, with the pregnant woman, and as we know, the field of nuclear medicine is very rapidly evolving, so I think we will always need some work to be done in this field. And I thank you, all of you, for your participation, all the members of the panel. Thank you very much for your time. It was very good inputs for us, very interesting inputs, and we hope to continue these contacts and this collaboration. Thank you very much to everyone.
And I would also like to thank everyone, and to the speakers, and to Augusto, our chair, and to all the participants who was listening to this, and for the panelists also. Thank you very much.
And to our support from the ICRP Secretariat as well.
Yes, of course. Thank you.
Thank you. Bye.
Bye-bye. Thank you very much.
Thank you.
Bye.